Hello everyone and welcome to AHP Leader YouTube Live. Now this session tonight is dedicated to a panel of UK respiratory physiotherapy experts, and I know they feel very funny when I say that, but they are. And the reason they're experts is because they are working on the front line in UK hospitals and have a wealth of experience in managing patients with COVID-19, either in the intensive care unit, on the respiratory wards, or across the whole pathway. So I'm absolutely delighted, first of all, to introduce our panel. And I just want to say, for those of you watching on YouTube, you need to be signed in to make a comment and ask a question. This is a question and answer session. Those of you watching on Instagram, you just need to jump over to YouTube if you want to ask a question, or you can DM me on social media. I can just see questions popping up there, so thank you, Jordan. And yes, I'm going to ask Laura to introduce herself first.
Hiya, I'm Laura Mylott. I'm a senior physio working within ICU at Guy's and St Thomas's Hospital, and I'm also the public relations officer, not relationships, oh dear, public relations officer for the ACPRC.
Thank you. Vicky.
Hi, my name's Vicky Newey. I'm the clinical lead physio for critical care at Imperial College Healthcare NHS Trust.
Thanks, Vicky. Amy.
First mistake, take myself off mute. Hi, my name's Amy Griffith. I am a physiotherapist on intensive care at Heartlands Hospital in Birmingham, which is part of University Hospitals Birmingham.
Thanks, Amy. Matthew.
Hi, I'm Matthew Quint. I'm a respiratory physiotherapist working in Portsmouth, principally in respiratory medicine, but also with some roles in critical care.
Thanks, Matt. Nat.
Hi, I'm Net. I'm a critical care physio. I'm normally at St Bartholomew's Hospital, but I've been redeployed to the Royal London Hospital.
Thank you. Ash.
Hello, my name is Ashwin. I'm a critical care physiotherapist working at Liverpool Heart and Chest Hospital in the northwest region of England.
Thank you. Catherine.
Hi, I'm Cath McLaughlin. I'm one of the clinical lead physios at Nottingham University Hospitals, working at City Campus.
Thank you. Pearlene.
Hi, I'm Pearlene. I'm the acute and IV lead physiotherapist at Birmingham Heartlands Hospital, and I'm the British Thoracic Society's critical care specialist advisory group.
Thank you. Rebecca.
Hello, I'm Rebecca Livingston. I'm a respiratory physio, and at the minute, I'm working on our Cpap units at UCLH.
Thank you. Now, Dips, I forgot to ask if I'm using your full name or your name I know you as, Dips. Sorry.
Dips is fine. Hi, I'm Dips. I'm the critical care lead physio at Northwick Park Hospital as part of London North West University Healthcare NHS Trust.
Thanks, Dips. And last but not least, Nikki.
Hi everyone, I'm Nikki Webster. I'm a critical care physio by background. I head up a fab team of physios at St George's in London. If my screen goes blank, it's because I'm eating a kebab and I don't think I need to share that with you guys. So I might dip in and out in terms of camera, just to warn you.
And Rachel, you've forgotten me.
Oh, Abby, how could I forget you, my pet? Off you go.
I'm Abby Oliver. I'm the advanced practice physio and rehab coordinator at Southport and Ormskirk NHS Hospital Trust.
Thanks, Abby. Appreciate that. So we're going to move on to our questions. Like I said, this is a question and answer session that people have already given some of the most common questions we're getting, but also please feel free to pop any in the chat box as well. So first question is secretions. So when I think back to what is nearly a year ago now, when we were first learning from other countries about COVID-19, we were told these patients didn't have a high secretion load, but in the first wave, we certainly found that they did, and we found that secretions were a real problem. So we kind of started to manage them, introduce humidification when we hadn't And now in this wave, second, third wave, whatever we want to call it, we are still seeing secretions a problem, but not everywhere. And I think the slight disclaimer I want to make here is that everyone on the panel is here with their own experiences in their own hospitals. Some have moved around a bit, some have the fortune of going to other centres and seeing what they do, but this is just our experiences. It doesn't mean it's the right or only way to do things, it's just what we are seeing in our practice. So secretions in intubated patients, are they still a problem, and how are we managing them? Now, Laura, I'm going to come into you first, please.
In short answer, yes, they are a problem, and yes, they are there. I think we did a bit of an experience piece after the first surge, where again we were initially told that they weren't phlegmy, and then we found that they were, and we went through a process of we use normal humidification for all of our patients anyway, so we continued with that, but we'd stopped nebulizing, and then we restarted nebulizing, and then also brought in a lot more carbamazepine via NG tubes. And I suppose as we've continued, we've just kept up our normal practice, using nebs, using humidification, and we are finding that they are phlegmy, and they do need physio, and we are using originally a lot of manual techniques, a lot of saline suction, and then as we've progressed, I suppose gotten more used to this cohort, bringing in our normal treatment techniques for secretion clearance, essentially.
Thank you, Laura. Nikki, coming down to you.
Yeah, I completely agree. It's a little bit of a misnomer that these patients haven't got phlegm. They absolutely have. We're actually seeing more so than last time. We would routinely find that there would be maybe 20% of the ITU that we just didn't need to go near. They were very, very dry. And this time, pretty much every single patient has got a degree of secretions that needs airway clearance. It's very tenacious, very thick. I'm not sure, we're getting quite a lot of bacterial pneumonias as well that we're seeing in this population. I'm not sure if that's because of the time of year that we're in, and we would normally be seeing a lot of bacterial pneumonias at this time of year, but certainly there is a lot of sputum there, and they need our help to shift it.
Absolutely, superimposed infection or COVID pneumonia, COVID pneumonitis, as we're seeing, definitely probably a combination. Ashwin, can I come into you, please?
Sure. We're definitely seeing loads of secretions. Phlegm is definitely a problem, but we have resorted to our manual techniques, and as Laura said, carbamazepine through NG tubes, and we've continued to use humidified systems and also nebulizers through the second wave and through the third wave, and that's really helped us to keep their chest clear as much as possible and be able to humidify them to be able to clear the secretions.
Thank you. And Vicky, coming over to you.
Yeah, I think we've seen similar things to what everyone else has mentioned. There is still the odd patient who will remain quite dry for the early phase, but potentially because of the use of using more high flow or Cpap before intubation, that maybe might be leading, because if they get some nosocomial infections on top, as Nikki said, then quite often we are seeing them become quite phlegmy as soon as we do intubate them. And definitely as they stay with us for the longer period of time, they do remain quite productive with very tenacious secretions throughout the whole time. And similar to what Laura said, we kind of have resorted back to treating them almost like they don't have COVID, you know, back to your normal treatment techniques. I think we're not as nervous, not as frightened, and we're back to using humidification and nebulizers again.
So humidification systems in intubated patients, this has come up quite a few times when I was asking for questions. So again, only speaking from my experience with patients on mechanical ventilation and vasoventilation, is that humidification systems like water humidification has been reintroduced as standard. I do have to say I've worked on units where it's not standard in normal times. So HMEs are the standard humidification method before someone's been ventilated 7 days. So what are people's experiences for those that would use humidification as standard? Has that been reintroduced completely? Catherine, I was going to come into you first.
Yes, originally in the first wave, probably the same experience as everyone else. We weren't using humidification, and we had a lot of problems with occluding ET tubes and ET tubes needing to be changed. And so we did push for humidification circuits. Towards the end of the first wave, we were humidifying circuits and using Fisher and Paykel's, which is what we use as standard. In normal population ITU patients, we use HMEs unless we think they're going to be ventilated for longer than 48 hours. In our trust, we do actually humidify them quite early. So we are using now Fisher and Paykel's. Some patients are on HMEs. If they're a rapid intubation and they need proning, then the circuits may not be changed until they're more stable. But what we're finding with the HMEs is that they are, because we're using 2 in the circuit, I don't know if people are still using 2 filters in the circuit. If you've got one which becomes quite wet, and if people aren't changing them quite as frequently because you have to clamp the ET tube and then stop the ventilator. So if they're becoming wet, then their airway pressures are going up and their CO2 is rising. So actually it seems that now that we're using the Fisher and Paykel's, we don't seem to be having too much problem. I think people are much more comfortable about clamping the tube, changing the HME, that kind of thing. And we're having less problems with secretions. Still loads of secretions, as everyone else is noticing as well, really thick secretions. And we use the maquette ventilators, which have the aerogen nebs in the circuit, which have been great because we just changed those ventilators during the first wave, which was challenging. But the aerogen nebulizers are great, and we're using carbocystine much more frequently as well.
Absolutely. Now, do you use carbocystine as standard, or do you wait until, because obviously there's it takes quite a long time to become active, if you like, there's quite a delay.
About 3 days or something, is it? But we're requesting it, or actually the medical team are much better at putting it, because normally we would request carbocystine because it would be us who discover the secretions are really thick, but now the medical team are actually putting it on much, you get to a patient and they're already on it.
Okay. Does anyone use a Dotten in their intensive care unit, just out of question? No, I think that was something one of my old consultants used to do, and it's like the domestos of mucolytic. It's about 45 pence a dose. So yeah, Ashwin used to always say that, and it's really, really effective. It's only licensed for 10 days, is the thing. So, but it's in the BNF as a mucolytic. So yeah, top tip. But I've not really seen it used outside of Preston actually that much in intubated patients, I have to say. Okay, so with the carbocystine, would you start a maximum dose, and then? Was that what you would do, Catherine? Yeah. Yeah, they go on to maximum dose, 250 3 times a day, and they seem to be. That's where we sit with them. We're having, I mean, interestingly, we are finding they are having these additional infections like Pseudomonas. We've seen quite a bit of, and we've had Serratia infections, and we had a group of patients with Aspergillus as well, so they were a bit more challenging. So we started testing for Aspergillus as a routine test because we had a few of them with that. Does anyone else want to come in on that comment? Humidification systems, Amy.
There we go. Hi. Yeah, I mean, on our unit, it's HME as standard. We don't really have many humidification systems, unfortunately. So from a secretion management perspective, I'm certainly using more saline than I've ever used before, which does help. Obviously, it's not the same as a heated circuit, but it goes some way. And certainly, as a gaggle of physios going around, one of the things we do a lot of is changing the HMEs, because as you've highlighted, some of them just get so waterlogged. And we've got so many redeployed nurses that aren't comfortable, understandably, to start clamping tubes and pausing ventilators to change a HME. So that's something we, do as part of our general check, really, when we're doing all of the other stuff that we're doing. But no, I'd love to see more heated humidification, but it wasn't a standard treatment before COVID on our unit, and it isn't now. If we really feel that it's indicated, and if we can find a spare unit, we can use it. But I have to say, but as physios, we're sort of saving those really for the patients who are trached, because then once they're trached and we've got a one-way valve in, we need that we need the heated humidifier for them. So that's sort of our experience.
And do you have much problems with blocked tubes and airway clearance and things, or would you say not?
No, we have. I think we may have had some blocked tubes, but not that I've been aware of in this wave. I mean, we're a much smaller unit compared to obviously some of the people that are on here. I mean, our usual is 11 ITU beds. We're sort of balancing at about 35 at the moment. So we're about sort of 300 to 350% capacity. But no, we seem to be managing it with saline. We're sort of doing the best that we can really with limited resources.
Thank you. Now, Nat, I'm coming down to you because you've got a lot of patients where you are, and you haven't really found a lot of secretions, have you, in your patient group? Is that because you've got good ventilators and you've got loads of fires?
Well, we've got 5 different types of ventilators, so that's a challenge in the first place. So I'm surprised. I thought we were going to be seeing more secretions than what I am seeing, just because of the experiences from the first wave. But the secretions that we are seeing are relatively easy to clear. Our humidification strategy is a little bit here and there, like some are on heated circuits, some are on HMEs. I think it gets to a point where we've got so many numbers that I think people almost don't see it anymore, and then you actually have to come around and actually just remind them that actually this patient has been here for 7 days and perhaps this is something that we might want to look at. In terms of our kind of management of our secretions, we're definitely looking at manual techniques and manual assisted coughs and positioning and those sorts of things, and that seems to work. And we've got the Aerogen nebulizers as well on some of our ventilators, which are amazing. They're really good.
Oh, I mean, they're amazing technology that's been around a long time. I feel. Now I'm just there's some questions coming through. Hypertonic saline versus saline nebs. I mean, that's controversial in itself with the ventilated patient, but is anyone using hypertonic saline in intubated patients? Put your hand up. Laura, Nikki, Catherine, Dips as well. I'll come to Laura then, Dips.
Yeah, we use 3% generally for most of our patients, but we will request it if we're having trouble with sputum. Normal saline tends to just randomly get prescribed, and then we'll just ask to upgrade to 3%. So yeah, it's just kind of part of our standard practice. It's part of our mucolytic guideline. It's more 3% saline rather than NAC, I would say, though NAC is also in our guideline. And then I'd say this time round, we seem to be starting to look at use of DNAs more than we did in the first. So actually nebulizing in DNAs, whether or not that's evidence-based or not is up for debate.
You just answered another question there. Dips, coming into you about hypertonic saline. I mean, 3% down in ET tuber through a normal nebulized system as well, is it, Laura? Sorry, you're on mute.
Yes, nebulized, yeah.
I mean, I can kind of understand like 6 or 7%, but is it effective? It's effective, yeah?
Yeah, we seem to find a difference. So we've just continued with that, and that's pre-COVID and post and during COVID. So
well, there you go, experiential evidence. Dips.
Hi, yeah, we've started using it just with a couple of patients. So similarly, we've got HME as our standard, and we've kind of got a mixed picture where we've got some patients who are actually quite non-productive, and then we've got another cohort of patients that are very productive, and they tend to be on carbamazepine, carbamazepine, regular saline nebs, and we've tried hypertonic with a couple of them, and it's helped us. We seem to be able to remove a bit more secretion. And yeah, we're finding it, like other people saying, it's very thick, very tenacious secretions.
Thank you, Catherine, and someone else was going to come in.
Yeah, we will use hypertonic 7% with patients that we're struggling with, so it won't be a routine thing. We'll just use it if we're kind of at the end of everything else that we can do and we're really struggling with them, or if we can't take them off the vent to use any of our adjuncts. We'll try using the hypertonic as long as they are stable enough and not particularly, wheezing all the rest of it. But yeah, we will try it with some. They're not all standard on it though.
Thank you. Is there anyone else that was going to come in there?
My practice is just essentially the same as been repeated. I'm interested to hear that someone else is using NAC. Personally, I think it's gopping and wouldn't want it at all. And the thought of using DNAs when you've got 7% hypertonic saline, which is cheap as chips, and then going to DNAs, it seems a vast expense. Now, if I've suggested using DNAs in intubated non-CF patients before, and our pharmacists tend to get a little, they blanch at the thought of the cost of it. So, I'm impressed that you've actually managed to get that past your pharmacist, because we just can't.
I'd say it is in very special conditions. It's not just being thrown around willy-nilly.
Very special.
Very special indeed. Now, there is a comment from Lisa just about they've had some experience of hypertonic saline causing salt crystal in the filters. I presume that's when you have a filter in the inspiratory limb and at the ventilator to protect the ventilator during COVID, because obviously we wouldn't have a filter at that point of the circuit normally. I suppose that's a good point. I mean, is anyone else? She said it might have been 7% though. Obviously, that's the saltiest formula that we have. Has anyone else found that or looked for that? Or
we've used 7% saline as a standard for our hypertonic for some time, and I've never seen salt deposits in terms of any filters, or actually anything which is deposited within the air pathway at a later stage.
Thank you, Matt. We've already got a comment about your passion on the chat box. Love your passion. Okay, so just a couple of comments as well about other units struggle with availability of heated humidifiers and being saved for the trachea or the Cpap. In terms of saline, how much do people instill in one suction? Now, this always comes up, doesn't it? I mean, I always, when I'm not doing a kind of blind lavage, is what I would call it, taught by a guy called Alistair Gascoigne in Newcastle, where we used to draw up 3 20ml syringes on a bladder syringe to do what we call blind lavage. I would just have a 10ml syringe drawn up and potentially put all 10 down in once, but I'd probably gauge it by like 5 mils and then another 5 mils. But 10 mils would be the most I'd put down with one suction. So that's just my 2 pence. What do other people do in terms of a suction, saline for suction manual techniques?
20 mils. I'll go up to 20 mils quite happily.
You go up to 20 mils. Any takers above 20 mils, below 20 mils?
I would happily go up to 20 mils as well. I mean, if we look at the amount of saline that goes in during a bronchoscopy, I don't think there's much difference much in terms of side effects that can happen from 20 mils of saline, honestly.
And that's a really good point. The comparison is with bronchoscopy. Yes, it's directed under bronchoscopy, but 30, 40 mils a shot, and then it's hoovered straight out. So if we're looking to mobilize and use it as just as much as a lubricant to get that large, it gets referred to as a dockyard oyster in Portsmouth, that large lump of sputum out, it really does just lavage it out.
Yeah, I don't disagree. Anyone else? What would be their standard? Be 10? Like, is there a couple of like 2 millers in the group? No, often, yeah.
I'd go 10 mils. 10 mils I find is usually enough, but then if you turn the patient, then go 10 mils the other side as well.
Yeah, I would have a good 2 or 3 10 mils drawn up with some extra ampules by the side. I know some people have to manually draw it out of a bag. I just like the ampules, and maybe that's why, because there's 10 mils in the normal ampules. But yeah, okay. Hope that answers your question. Okay. So are we finding the patients that have more secretions are those with comorbidities or who are being diagnosed with ventilator-associated pneumonias? Or we're seeing, I think for me to answer this question, there's patients that come in with almost COVID pneumonias, COVID pneumonitis, and that have a very inflammatory edematous lung picture. You can see that on chest X-ray, you can see that on the CT scan. You have the patients who have evolving pneumonia that you would typically have when someone's invasively ventilated. And then you have the patients who have pre-existing comorbidities that may predispose them to a ventilator-associated pneumonia. So I think in my general practices that we're seeing a combination. Can you predict who's going to get secretions over those that can't? To some degree, but not always. It's a complete mixed bag. So I think the prevention is often the best thing. So positioning, early proning if patients are on high oxygen requirements. So again, that would be mine. Does anyone want to come in and offer their 2 pence worth to that question in terms of, do the patients that get secretions tend to have existing comorbidities? Or is it just a general mix match? Abby, can I come into you? Oh, and then Laura.
I'd agree with you, Rachel. I wouldn't say, I mean, there's patients that might come in that, you know, existing respiratory conditions that you might expect that they're going to be, you know, particularly more productive than others. But I'd like to say that we could guess who it was going to be, but I think one day they're not productive and then you turn around and all of a sudden there's absolutely tons and you end up spending most of your day with the patient you weren't expecting to. I couldn't give you a black and white. I think it's pretty general, personally.
Thank you, Abby. Laura.
Yeah, I was going to say the same thing, really, that it just varies so much patient to patient and day to day, but also we've got quite a young cohort of patients, so ones without any other medical issues, and they're phlegmy as well, so it's just very, very variable.
Thank you. Okay, modes of ventilation. We get asked this quite a lot. What are the best modes of ventilation? I suppose another way to ask this, because there's so much variance here in the UK about what is a preferential mode of ventilation for patients who are on invasive ventilation. In terms of generally, we see people on conventional modes of ventilation, I would say, as a rule, so either volume or pressure control ventilation, moving on to some of the more sophisticated or more innovative modes of ventilation, for example, APRV. But I think we had a nice discussion at the beginning. Abby, I think we came to you first in terms of what the ventilation strategy would be for in your centre first, and then what you'd move on to if the patients weren't responding or becoming more oxygen, you know, hypoxemic. Or do you want to start us off?
Yeah, so I'd probably say pretty routinely most of our patients are ventilated pressure control ventilation. So after an intubation, we'd expect them to you know, be pressure control mode. I'd say then if they're ramping up and they're quite hypoxic, which, you know, typically they are, we're keeping them in that mode because they're usually requiring paralysing to be proned. So quite early on, within the first 24, 48 hours, we might be paralysing them and then proning them. So personally, APRV, I believe, isn't a mode that a patient should be paralysed in. I do think you need them to be blowing some of the CO2 off. So we might move to APRV kind of if proning's failed, if paralysing them, we've not managed to control the ventilation that way, and if hypoxia is still an ongoing issue, we'd want to try and lighten them a little bit from the sedation, try and not have them so paralysed, and then might try things like APRV. Or if we can't manage that because of other issues and we're needing them to be paralysed, we might just end up with really, really high, uncomfortably high peeps in some patients that we've just not really got any other options for.
Thanks, Abby. Nikki, coming down to you.
Yeah, very similar picture actually to Abby. We tend to start off with pressure control, plus or minus paralysis and proning. We do use APRV, and again, we don't routinely use APRV in our paralysed patients because it's essentially analogous to pressure control ventilation if there's no spontaneous breaths. But we do use it with those patients who've tried and failed pressure control and proning, or those patients that were wanting to lighten up a little bit but still have incredibly high oxygen requirements, big difficulties with oxygenation. We're finding it works quite well with the asynchrony patients as well. It's essentially those ones we're just trying to lighten up for a little bit. We had a conversation before all this about pneumothoraces, and I think some centres have experienced patients having pneumothoraces with APRV. As far as I'm aware, we've had one, but that patient did have multiple pneumothoraces with APRV. So yes, it's very much a risk factor, but we haven't seen lots of patients experience that.
Thank you. And Catherine coming in, and then for anyone else for comments on that.
Well, like I say, halfway through the beginning of the first wave, we moved from the Draeger XL to the Maquette ventilators, which was challenging. And going from pressure controlled ventilation, which we were all very comfortable with using BiPAP ASB, we are now using a lot of PRVC, SIMV, PRVC. So they have a backup rate, but essentially they're volume controlled, which, you know, is obviously different to what we're used to. But some of them are needing pressures, peak pressures of upwards of 26 to 30 centimeters of water to achieve their volumes. If they aren't ventilated to that level, then they don't gas exchange, and they're really quite, they're obviously needing a lot of proning. So as soon as you turn them prone, that seems to come down, and then we can come back on the pressures or on the volume. But that's what we're using, and then we are using a lot of bivent APRV, and on paralysed patients as well. And I know what you're saying about them needing to go off their CO2, but some of the patients do quite well on it, even when they're completely flat and not particularly being involved in the ventilation. Maybe it's to do with the settings or the frequency of the exhalation or whatever it is, but they seem to do okay with that. Yeah, so those are they're the main things, but it's taken us a while to get used to those different modes of ventilation because it's all quite alien to us.
Yeah, and I think we've got to think about the pathophysiology as well of what's going on inside the lung with these patients, and as much as it can be one underlying physiological process, it's often underlined by other significant things that are going on within the lung regarding fluid balance. If we're trying to keep things dry, the hit on the kidneys, it's a whole complex multifactorial ventilatory strategy, isn't it? Then combine that with a bit of mucus, then combine that with the inflammation, then combine that with the airway. I think this is the challenge, isn't it? Now, someone has commented about peak airway pressures and plateau pressures, how we're managing them, how do we know when we're creating trauma because of some of the higher pressures that are needed. So I'm going to talk about like airway pressure and then talk about PEEP. One of the things that I have found quite startling is being unable to predict the compliance of the lungs in some of these patients. And some people you think are really hard to ventilate and they've got really bad compliance, but actually the compliance is okay. It's just because they need really high opening pressures or driving pressures. Or so who wants to come in by starting with that? How do we look at airway pressures? Are we concerned about them? Does anyone have an opinion on it? Vicky, I know that you guys, Vicky and Nat actually, so I'll come to both of you in terms of look at airway pressures and look at compliance as well. Have you got any comments on that?
Yeah, I think you have to weigh up all of the factors, as you said, Rachel, really. I think in the first wave, we really, very early on, everybody kind of thought that they're on really high FiO2, they would need really quite high peak requirements. And I think that changed very rapidly as we kind of started to see some of the patients through. As you say, some of them did have really high airway pressures, but actually when you looked at their compliance was relatively normal. And they actually did much better on a PEEP of around 8 to 10, even when they were on like 80 to 90% oxygen, which kind of went against what you usually went against your normal rule with all your ARDSNet and your kind of FiO2 ladder with your PEEP. So I think we quite quickly looked at that, and I think it's important to have a look if you do have an understanding of what you can see on the ventilator in terms of PEEP and compliance, and if they are gas trapping or anything related to that, because often we found also that they were on such high peaks, it was actually affecting their hemodynamics as well. And actually when we did bring their peak down, their hemodynamics improved as well. But then again, you do get those patients that have got really terrible compliance, really high airway pressures, and you would be more worried about it, really, I think, especially if you think these patients are more at risk of actually having problems if they've got quite fibrotic lungs already, or there are risk of kind of further trauma and kind of blowing pneumothoraces, which we have seen. So I think you do need to weigh up and look at your compliance, look at your driving pressures, look at your plateau pressures, and look at your PEEP, and really try and base it on the physiology of what is actually going on with your patient, what stage of the process they're in. Are they in that more fibrotic stage, or then there's that inflammatory phase with normal compliance or not with a normal compliance? So I think every patient is ever so slightly different. They kind of bunch into one or two categories sometimes, but you do need to kind of weigh up all the numbers, I would say.
Thank you, that was very comprehensive. Nat, you've got to follow that now.
Yeah, I know. I was just about to say, Vicky, man, I've missed you. God, I missed those conversations. No, so I completely agree. I can't top that one, but I think for our team, they're very much looking at the peak airway pressures. They're like, very concerned about the damage that they might be doing with the ventilation strategy. So there is an acceptance of higher CO2s off the back of that. So they're really looking to make sure that those peak airway pressures, those plateau pressures are not in extremis. And so like they'll be targeting things something like 7.2 as a pH and just completely accepting it and not worrying about the CO2 whatsoever. And then again, having a look at your PEEP strategies and making sure that how are we recruiting these patients and having a look at their compliance. So.
Well, you've just brought one nicely in there, Nat, to the next set of questions that are coming through. So a very quick one about ventilator hyperinflation in APRV. Can you do it? I mean, I'm like, no, but because you just you have such quick releases. Can you? No, Nick, I'm looking at Nikki. No, I'm not as familiar about it to answer that question.
In all honesty, not really, not very effectively at all. You can pretend you are. You can stand next to the ventilator and press the buttons and pretend you are, but really, it's just APRV.
Thank you. So moving on to and we actually haven't been asked this aside from in the live chat box about manual hyperinflation and ventilator hyperinflation. So are we using it as a recruitment strategy for patients? So I mentioned, ongoing oxygenation problems, de-recruitment in that weaning phase. Are people using it as a weaning strategy as well? So either ventilator or manual hyperinflation. So to start with ventilator hyperinflation, is anyone using it as a strategy to either recruit or help wean? Yep, Nat, off you go, back to Nat.
So we very much use VHI, not so much as a wean, but as a tool to help clear secretions. But that's within the parameters of what's going on with that ventilation of that patient. So if they're demonstrating like high peak airway pressures and so on and so forth, then you might be a bit limited about what you can do, and you might only be limited to inspiratory holds and some manual techniques and some positioning and so on and so forth. But yeah, like we do use it, but we just select our patients quite carefully.
And is there a particular mode of ventilation it works well in? And if so, like, would you have a set number of cycles you do in terms of...
So you can, so I'm not familiar with APRV, like we don't use it. So we use volume control, we use pressure control, and you can use it in both modes. But it's kind of just you make it up as you go, basically, depending on the patient and what the yield might be. And, if you think that might be a tool that you can use to help clear those secretions, then go for it. But if it's not successful, then don't keep hammering away at the patient with, inspiratory holds or at higher volumes or at higher pressures.
So I know some centres have protocols for this. Nikki, I don't know at St George's if they still have VHI protocols, which is related depending on what mode of ventilation you're on. You'll give a set volume for a set time and pressure vice versa. But I think some units are very protocol driven with this, aren't there? And some units maybe just have a bit more, they look at the ventilator data as they're doing a recruitment manoeuvre, using the ventilator, and then how the patient responds as well. So I think there's probably, would people agree with that? There's probably different practice in different units. And now manual hyperinflation. Now I have seen this, obviously it was an absolute no-no in the first wave, but actually in the second wave and now in this wave, I do see it being used as a therapeutic intervention for recruitment. So clamping the AT tube, giving people manual breaths to help recruitment. Is anyone using that on their unit? Anyone know? Or it's just me that's seen it? Okay.
I use it occasionally if it's absolutely indicated, and well, I suppose if they plug off, and then we need to bag them, because we try and steer away from it if we can, from disconnecting them from the ventilator if possible. But especially the patients who are in their very early phase of the virus, because of their ability to be shedding and all the rest of it. But if they're a bit further down the line, then we might use it a little more freely. But yeah, we tend not to if we can get away without doing it, but we will.
Yeah, I'd definitely see that. And I think when it is used in an emergency situation, there'll often be, some people have the plastic sheets they'll put over faces or ink or pads to help reduce the aerosol spread. I mean, so yeah, I've definitely seen some different things in different units. Who else? Laura, were you going to come in there?
Yeah, I was just going to say that we generally use it, well, we might use it for secretion clearance rather than anything else, or in an emergency situation. But yeah, we have bagged a few of the COVID patients for phlegm reasons, essentially. But they've got a filter on them, and we clamp the ET tube to change over, and to put the vent on standby. So I think from an aerosol perspective, it's probably as safe as doing the cough assist.
Sorry, I was trying to mute where that went past. I would absolutely agree with that as well, and I think it's really hard when you've not exhausted your other airway clearance techniques, but when what becomes your biggest priority, and that is a tool that we'll have in the toolbox. So a bit like moving on, I'm going to jump into mechanical inexflation and other positive pressure devices. Again, in the first wave, it was something that we were definitely going to steer away from, but actually in this wave, we have seen the reintroduction of airway clearance devices. So, Pearlene, can I come to you first for your opinions on this, in terms of have you been using them in both the intubation and the extubation phase?
So I predominantly I work on the wards, and for those patients, in terms of using MIE, we've actually steered more away from it, like in the first wave, mainly just to mitigate the spread of infection more than anything else. We're obviously limited on side rooms, and we just tried to prevent it from that point of view. I work with Amy, and Amy works on ITU, so her experience in terms of whether they use it more on ITU is probably the better person to go to at the moment. We talk about Cpap. It's definitely a modality used, and I think it should probably be used a little bit more for weaning patients, especially when it comes to patients with potentially like OHS or OSA or undiagnosed, just as a way to bridge that gap, really. And I think it's a really good tool to use for facilitation of weaning.
Thank you. Thanks, Pearlene. Laura, coming into you.
Yeah, so during the first surge, we held off on things like cough assist with our tube patients, but then on a case-by-case basis, we made the decision that if it was completely indicated and we were struggling, we'd have a discussion with the consultant and use it, whereas this time it's back to us from a autonomy perspective. If we feel that that is the only option for that patient, then we will use it, bearing in mind if they're in maybe more the early stage, or they're having issues with de-recruitment, or they're on high PEEPs, then obviously there are some contraindications to use the cough assist. But we're definitely using it as we would do kind of day to day before COVID, I would say.
Thank you. Rebecca.
Yeah, so we're using positive pressure quite a lot with our Cpap patients. We're just finding that for the patients who are on Cpap for a long time, that continuous pressure is sort of pushing phlegm down into the airways, and it could be a few days before we've really realised it's there. So we are quite routinely switching into like an ST or a bi-level mode, so we don't have to disconnect them, and giving them some sort of larger tidal volume breaths to see if it mobilises anything. And that's helped us to kind of pick up any secretion load early and kind of keep ahead of that. And it has just been a very useful alternative to kind of disconnecting somebody from Cpap when they might be on, you know, fairly high levels of PEEP.
Thank you. And Nat, I think Nat was going to get you to comment on this.
We haven't been using MIE in ITU, not because we don't want to, it's just that we haven't felt the need to yet. I think I'm still keen to give it a go on the right patient, but I think I would just be really careful about the type of patient that I would use it with, and depending on what type of phase their lung disease is at as well, and really paying like close consideration in terms of you know, what support they're on at the time and what their lungs are doing later as well.
Thank you. And just a quick question about using the cough assist or mechanical inexablation with ET tubes or once tracheed. Well, you can use it with an ET tube, but not every centre will either have the confidence to do that or have the ability to do that. But yes, it can be used through both. In COVID patients, when centres are using it, I believe they are using it with both. So yes, that would be just to answer that question quickly. Surgical emphysema. Has anyone had any problems with surgical emphysema? Yes. Okay, so I haven't had experience of this. Laura and Matt, I can see you nodding. Matt, can you come in?
Well, we've had a few problems. We've had actually in the second wave, we've had far more problems with barotrauma full stop. So we've had surgical emphysema, numerous pneumothoraces, and I think, is it 4 or maybe even 5 pneumomediastinum in terms of either non-invasively or invasively ventilated patients. We're not entirely sure why we didn't have this level of barotrauma on the first wave, but certainly in the second wave, we've had larger numbers, so that might be a bit of accounting for it. They are a challenge to manage, though.
Thank you, Laura.
Yeah, I would say similar. I mean, it would be good to get true numbers on this. We've had more patients this time as to whether there are more this time versus last time, but we've got extensive numbers of pneumothoraces, pneumomediastinum, a lot of, but we are an ECMO centre. So if their barotrauma is that significant that they need to come off positive pressure, then obviously we're going to have them on ECMO. So maybe we do see a higher proportion because of that. Though I know the ECMO network did put out a consensus statement about they do all seem to be seeing a lot more barotrauma coming through to the ECMO centres, and whether that has any relevance to being on Cpap before intubation, or how long they're on Cpap before intubation, or if it's just COVID and this is what happens. But it does make it quite difficult from a physio perspective in terms of treating these patients and managing them, and also their ventilatory settings, I would say.
Our practice hasn't changed hugely in terms of the level of positive pressure we give before these patients. In fact, the only difference is we're probably using more high flow in this section because we're now in a position where we can. So for us to see that much more barotrauma, especially the pneumomediastinum, has been a bit of a surprise for us.
Okay, Matt, do you want to take us on to that next point then about using high flow Cpap as an extubation strategy? So I know that you got a lot of experience on the ward and in the acute medical units, but in terms of what would be your opinion on using it, particularly for those the patients we might predict might have more problems?
So you need to think about why the patients might benefit from high flow. There are 4 key things which we need to think about. It meets their peak inspiratory flow. So when they're breathing in hard, it's going to, if you give enough flow, it will actually take that work of breathing away. It provides that 100% humidification to the upper airway, so it helps their mucociliary clearance. And if you look at the energy rating of an air valve, or whatever your preferred form of high flow is, it actually takes up quite a lot of energy. So that is taking a lot of energy away from what your upper airway is going to be doing. For every about 10 litres of flow which you deliver, you get about 1 centimetre of PEEP, which is delivered. So you can get that effect of either getting over what's going on in the upper airway, or just sliding them up the compliance curve to get an improved volume. But I think the key point in terms of extubation is the effect on the dead space. If you get adequate flow, you're flushing that dead space. So what you're in many respects doing is you're giving them a non-invasive tracheostomy. So you can actually deliver a decent level of flow, and then you actually reduce their work of breathing significantly. And I think that's the key to using high flow, and it has to be high flow. You're not talking about a homeopathic 20 litres per minute. You need to be going for at least 40, 50, probably 60 litres per minute. And if you can use some of the other systems which go higher and the patient can tolerate it, you can get away with it. So I think it's an excellent strategy. There are concerns about it being aerosol generating. I think if you look at the nerve tag data, which the original decision was made on, it was based on 2 papers. One which looked at bacterial colonies and was reasonably reproducible, and another which was utterly unreproducible, and you couldn't get any decent data out of it. And there was a comment made in the original nerve tag data saying that if you can't see the mist coming out of the end of a nasal high flow system, it isn't working properly. Well, if you can see mist coming out of a high flow system, it's not working properly, because this is water vapor, not an aerosol. And there's certainly some data to say that that high flow going into the airways reduces the particulates being generated. But if I start talking about aerosols and droplets, I'll keep going forever.
And there's some really nice papers on infrared technology looking at droplet spread, isn't it? Because it's about the droplet spread, like you said.
It's not just the droplets, the infrared data. There's some lovely flow dynamics. There's some data using lasers and smoke, but smoke is not an aerosol in its truest sense. The Bristol group is doing some great work. There's an aerosol Bristol group, and they're using laser particle size systems, but they're measuring it at point prevalence. So you essentially suck the air in at a certain point, and then you measure the particle range. But you can only do that at one point. And they're finding the sensitivity of the systems which they're using, and they have to do any of their data management in a laminar flow theatre. And then you need to differentiate between aerosols at up to 10 microns and then droplets at larger than 10 microns. And then you get onto a whole new field of splatter and droplet spread and ballistics rather than the aerosol deposition.
And that kind of brings us on to a question in the chat about suction, open versus closed suction. Now, I think there's a difference here in terms of, in an intensive care unit, generally they are red zones. They are zones where we have enhanced PPE. Initially, there was, you would very rarely, like if we think about trachea suction as well, and AT suction, not use a closed system. But I think if in the this is just my answer of this question, and when the situation dictates for you to use an open catheter for a longer suction or for more effective suction, or if you're using more saline, then that would be something that I would do. I mean, it depends if you have the connectors that have a port where you can suction as well. So I don't know what other people's experience of, but I certainly wouldn't say it was you always had to use closed suction. If the situation meant disconnecting the circuit or using an open suction technique, that's something that I would do. Has anyone got any comments on that, or an agreement? Or Matt?
Yeah, I'd agree. I feel quite comfortable about suctioning people, with the caveat of making sure that people are wearing the right PPE in that environment, because you have to remember, breathing is an aerosol generating procedure. And then when you're actually asking that patient to cough on top of that, you are going to get that mix of aerosol and droplet, which is transmitted over quite some distance. So yes, do it, but make sure that you've got that PPE on.
Yeah, well, Public Health England don't think that. It's an AGP, do they? For sure.
There will be data coming out, hopefully at some point soon, to give them second thoughts on that.
Pearlene.
I was just going to add on to that with PPE. If you're sort of suctioning on the wards, it's also sort of offering the patients just a little mask, just to help protect them as well, as they're the ones we also need to protect too.
Nice point.
Thank you. Okay, trachees and weaning COVID patients with high BMI. So I'm going to try and combine the two here. So is anyone performing or having experience performing early tracheostomies, i.e. less than 7 to 10 days in this patient cohort group? I think the answer is no. We did have a pre-chat about this. So on average, it seemed to be from the pre-chat, it was around the 20-day mark in terms of tracheostomies being performed. Now, who am I going to come to first? Ashwin, can I come into you first in terms of just your experience of tracheostomy timing and what type of patients you've seen it in?
Sure. I think it's been quite an individual approach to each patient as to who's ready for a trachea and who's not. I think the median, I would say, is between 17 to 20 days. And we would go with the regular criteria with FiO2 less than 50 or 40% and PEEP of less than 10 and a PF ratio of less than 150, and we would identify patients that we would think would benefit from having a tracheostomy, and basically on a case-to-case basis.
Thank you. Amy?
Yeah, I mean, we seem to be doing them slightly later. So generally, at the moment, they're somewhere between 20 and 25 days, again, depending on various different reasons. You know, some of them, the ones I can think of at the moment, have had a failed extubation to Cpap, and then have been retubed and then have been subsequently tracheed, or ones that we predict will fail their extubation and then we'll just go straight for trachea. Probably seeing more trachees in the larger patients because we are predicting that longer weaning process, which obviously is great for us because then they're awake. They're very much easier to rehab when they're awake, and can communicate with us. But I would probably say, if as a percentage wise, it's probably about 15 to 20% of our ITU patients at the moment get tracheed. About that.
Thank you. Again, first wave, we didn't think we were going to trachea any of these patients. Then we realised to wean them, we had to trachea them. We realised there was airway complications, edema, sometimes laryngeal dysfunction. We didn't have that in the middle bit so much, but Vicky, I know in your centre, you're still seeing a lot of those airway complications that we're seeing so much of in the first wave.
Yeah, I think it's not every single patient, but we definitely are still getting those patients that do seem to still have some laryngeal edema, or those that have some laryngeal dysfunction just as a problem of being intubated for that longer period of time. And especially, I think we can't rule out the fact that we're turning these patients into prone so frequently and then moving their heads. You know, you're going to have movement of the tube during that process. So I think it is always important to consider and, you know, work very closely with your speech and language colleagues to ensure that we are pushing these patients forward as soon as we can. But I would always make sure we're doing some kind of either airway examination with the speech and language doing their fees, or ENT scoping, or just having something to make sure that you are sure that when you are decannulating these trachees that the airways are patent and they're not going to have problems further down the line.
Absolutely, and I think there's actually just a question come in about cuff deflation, but I think this is absolutely where speech and language therapists come in, because they can often spot earlier signs and what we can actually visualise in the upper airway, being able to predict not just you doing things like cuff leak tests, but actually just visualising the airway. And Nat, I believe you're moving to, or trialling to, forgive me if I'm wrong here, a 7-day SLT service for some of your trachea weans, is that right?
I think they're trying to go to 6 days. So because we've got quite a lot of ITU beds and therefore quite a lot of trachea patients. And so they are trying to step them down off the unit basically as soon as they come off ventilator or organ support. So they will be stepped down into a trachea area, although we have got a bit of a backlog on that now. So our speech and language therapy colleagues are, you know, as well as the physiotherapists are hugely essential for that. So it's almost sad in a way because I don't get to see the decannulation. So I haven't seen that part of it, but I understand they're going very well. Like they're decannulating very quickly for our ones. So yeah, it'll be interesting to see if we're seeing kind of what Vicky was saying in terms of laryngeal edema and things like that. But so far, so good.
I think they do, as you say, they do definitely wean quickly. And I think not always all the patients, but majority of them don't have neurological dysfunction. So actually you can get that cuff down for a long period of time, get the speaking valve in either in line or early use when they're on the trachea mask. So actually the weans are what you would class as relatively straightforward, relatively easy, and I do actually go quite quickly. I think probably because they've been done that a little bit later. So, but I think, yeah, just the airway problems we are seeing a little bit of.
Thank you, Vicky. Pearlene.
So it's just to sort of go on Natalie's point. I was expecting when we had the tracking patients a little bit later on that the patients would be coming to our ward as a decannulation ward, but actually they seem to be doing really well and are decannulated before they get to the ward. Just like Vicky said, they're actually really good in terms of their rehab from there on. So it seems to be working.
Thank you.
I would just like to add on that a lot of the patients on our unit have been prescribed proton pump inhibitors, where laryngopharyngeal reflux has been identified as a causative factor for laryngeal edema, as opposed to a long intubation, being intubated for a long period of time. So definitely ENT and V's input has helped identify what exactly the causative factor is before defining any treatment strategies.
Thank you. That's really interesting. Dips, coming down to you.
Hi, in terms of the timing for trachees, we're finding, whereas we've only done about 6 trachees, and I think that's mostly been because from where we are at Northwick Park Hospital, we've had quite a large percentage of patients coming in and we're stabilising them, and then they're actually being transferred out. But for those that we have done trachees, again, it's generally around 10 to 20 days. There was a patient that we did a trachea on 7 days, and then another one that was around about 27 days. The difficulty is just trying to think about when they're going to be in a period of stability, when we've, they don't need to be proned, and a lot of our patients are needing proning quite a few times. So it's making sure that they're out of that period where they're not needing proning, where we're able to come down on their PEEP, able to come down on their FiO2 as well.
Rachel, you just muted.
Sorry, Rachel, you're on mute.
Thank you. Thanks, everyone. I think that's a really good point, Dips, and that's one of the reasons why early tracheostomy in this patient group hasn't been advocated from the beginning, really, because of the average length of stay is so long, it's over a month, and because of the incidence of proning being repeated as well. So thank you all. Has anyone else got any comments on that before I move on? Thank you. So moving on to proning, and then this is going to take us on to the last half hour, which is all about ward-based and all about rehab. So thanks for everyone being so patient. So proning in sedated and awake patients, or conscious proning on the wards, is it still effective? Are we still using it? So let's talk about the intensive care unit. Abby, can I come into you first?
Yeah, so we had a discussion earlier. We definitely are proning. We're proning early. I would probably say, well, definitely for us, if we want to refer someone for ECMO, we need to have at least tried proning them first before that can even be considered. When we're doing it, I wouldn't say necessarily in the first wave, I felt like they proned, you saw quite profound effects quite quickly. I would say they possibly aren't. We're not coming down on oxygen requirements so much this time, but I would say they're more stable when we're stabilising them a little bit more when they're over. I would also say that they're possibly not seeing the benefits of it the first time we prone them, but maybe second or third time we're seeing a bit more benefit from it. I feel like sometimes things kind of, we pick proning at specific times in the day where we've got more staff around, so we try and get them over later on in the afternoon and then get them back in the morning, so you can get 16 hours down. I would say a period of stabilisation is maybe what we gain from it, rather than huge, their oxygen requirements massively come down. We might all just kind of go, they don't look like they're going to horrendously go off for a little bit of time while we gather our thoughts and maybe try it again the next day.
Thank you. Now, I think Dips and Ashwin, you had comments around this as well, didn't you? I really like that concept of stabilisation as well, rather than a therapeutic intervention / carryover that we're initially using Pronen for. So Dips, can I come into you?
Yeah, so similar to what Abby is saying, is we're not necessarily always seeing a big difference in terms of the PF ratios or FiO2 coming down, but it is holding them and it is stabilizing them, and quite often we're doing it, seeing how long we can have them prone for, but they're doing it repeatedly, so it might be the next day, the following day, so they may actually end up being prone 4 or 5 times. What we're finding at our unit, they're being intubated and pretty much everyone is then being prone straight away. So we're still big advocates for proning on ITU. We're certainly proning a lot more patients who are self-ventilating as well, so on Cpap, out on the wards. And I think one of the things that we've been finding for those patients is actually getting a lot of thoracic, neck and shoulder issues that we're then thinking about when we're getting them rehabbing on the wards.
Thank you. Ashwin.
Yeah, definitely in the second wave, at least with my experience, we weren't proning as early, at least that's what I observed on my unit. And I felt like it was more used as a rescue strategy, which was, we've tried everything, the FiO2 is not coming down, and this is our last option to see if this makes a difference or not. The other thing that I've noticed that a lot of these patients benefited from having a physiotherapy assessment prior to being supine, because having that quick assessment, good clear of secretions prior to supining. Otherwise, a lot of these patients, once you supine them, blocked DT tube, sudden desaturation, and then leading bronchoscopy. So it was a time we made sure that we timed with the supining time so that we saw them before supination. So we had a good physiotherapy session, good clear of secretions, and then the patients were supine. And then if needed more physio treatment, then we would continue after the patient being supined as well.
That is such an excellent point, and I'm so glad you've mentioned that completely. Does anyone else have any comments on Pronen in the intubated patients before we move on to the ward patients? Laura, and then Rebecca, I'm going to come into you next.
I think, yeah, Ashwin makes quite a good point there, and actually it ties in with the stabilization, because actually they might be more stable in prone on lesser FiO2 for you to then do your physio intervention, whereas when they're flipped supine and they're then on maybe 100% oxygen, you haven't really got anywhere to go. If you do shift some phlegm and they do plug off potentially, you're on your max ventilator settings, you're on your max FiO2, whereas in prone, they're a bit more stable, you've got a bit more scope to treat them, I would say. So just to echo both, I suppose, Abby and Ashwin there.
I think it was just a matter of revising your manual techniques, where you probably need 2 physios as opposed to 1 physio when the patient is in prone to do your ribs and your manual assisted cough. So I think that's something to bear in mind, where it might not be a 1-person job where you need 2 people to help you with that manual technique.
Thank you.
The other thing I would just add into that is just nasal secretions. We're certainly finding when we're just about to then deprone patients is a lot of nasal secretions. So it's just reminding nursing staff as well as us that actually look out for those as well.
Again, really good point. Thank you.
And Rachel, can I just jump in? One last
Go
thing
for
on
it.
that. Sorry, I can't find my raised hand thing. Just in terms of the ability to perform decent manual techniques on a patient, particularly in our larger patient population, it's often significantly more effective when they are in the prone position because of the distribution of adipose tissue. People are often not quite so large on the back as they are on the front, and it's a lot easier to actually physically get your hands on and to make sure that those manual techniques are more effective in that prone position.
Thank you, Nikki. Rebecca, can I come into you in terms of conscious proning? Anyone who has any comments? Pearlene, I'll come down to you after Rebecca.
So we, with our Cpap patients, have worked more with kind of positioning. We found that proning is helpful. There are many patients who don't tolerate full prone, and so there we found side lying or prone sitting, so sitting on the edge of the bed, forward leaning over pillows, sort of on a table, as good alternatives. And we're trying to do that kind of proactively early on. You know, they come onto the Cpap unit, we're doing everything we can to kind of optimize them and make sure that we can, where possible, kind of avoid intubation with kind of doing everything, and sort of positioning is a key part of that.
Thank you, Rebecca. Again, really good points there. In terms of, there's a couple of questions about length of time. So in terms of positioning, so if you think about 3/4 prone or side lying or prone, is there a time, minimum time you'd have your patient in that position for?
So I think it comes down to what the patients tolerate. You know, because they are awake, they move. Some of the patients move out of those positions. They, you know, so we might find some patients, you know, are only there for sort of 20 minutes or so. But we have said the kind of 2 to 4 hourly position change. You know, the awake patients, they won't, or we haven't found that they will tolerate, you know, long periods. And we've had 1 or 2 complications where patients have kind of tried to prone for longer. So we're sort of saying every 2 to 4 hours to change position. And having those 3 positions provides kind of alternative positions that provide sort of similar benefit that the patients can move into.
Thank you. Pearlene.
Sort of on that question, I'd go for as long as they can tolerate, but 4 hours might be, or in my experience, 4 hours might be a bit too long. But again, obviously, if somebody's tolerating a slightly different version of that position, sitting on the edge of the bed, for example, then I think if it works, it works. Go for it. For the first, in the first wave, definitely work using prone or conscious proning as often as we do now. You know, the ICS recommends using it as when you're using more than 28% humidified oxygen, which I think definitely has been something that's changed in the second wave, and patients are using proning a lot more earlier on in their admission than they were previously. And the benefits, you know, they're pretty much as simple as the theory is. It improves your VQ matching, reduces your hypoxemia, it reduces the shunt and recruitment of your posterior segment, so you can reverse any atelectasis. And in the early stages, particularly, I'm not seeing many secretions, but I guess potentially it's preventing secondary infections as a result. So it's definitely something I'd advocate.
Thank you. As a strong advocate. Now we're moving on. I've got a quick question about humidification in Cpap, which I'll start with Matt for. But quick question about P0.1. Is anyone using it as a diagnostic tool for assessment for extubation, readiness for extubation? I think the question is. So for those of you that don't know what it is, basically it's something that your ventilator can perform as a diagnostic, which is an occlusion or negative pressure. Is anyone using P0.1 in this patient population? Vicky?
Yeah, I think we're using it as we would do with any of our patients when you're looking at their weaning ability. So looking at both their demand, so with their P01 as well as their capacity, so looking at things like your negative inspiratory force or your PI max, or however you measure some form of inspiratory muscle strength, alongside, you know, what you would normally assess for readiness for extubation or readiness to start weaning. I think I would just treat them as a normal patient that you are going to extubate, and I think it's a very useful value, especially for those patients who are really in both in extubation and also just throughout the process. So some patients, when you try and get them awake and they're having that kind of up and down dips that a lot of the patients seem to be having, even more so in this wave, when they suddenly become so air hungry and they're really gasping on the ventilator, it's just another value to help, either to just promote lung rest and increase sedation again, or as a readiness for extubation. So yeah, I think we're definitely using it in our centres.
Thank you. I think it's still something that's not on trend in the UK, but where people have the ability to use it, it is used, I think, is my general experience. I'm going to answer this question quickly because it's about above cuff vocalization. Should we be using it, and do we using it? The easy answer to this question is, in the right patient, absolutely yes. But it's a skill that many underestimate. It's not just something you can just do. It involves absolutely understanding the mechanics of what you're doing and having people who know how to explain it to the patient. You know, people, you can use it when people are in theory sedated. I mean, I would often question the rationale of that, but certainly in your weaning patient that's awake, that you want to use as a communication tool, and also to aid with laryngeal hypersensitivity, or you want resensitization as well. So it's definitely something you should do, but I would advocate as someone with experience and with your SLT as well, and being able to visualize the area in patients that don't respond very well is really important as well. So having some instrumental assessment via video laryngoscopy would be my advice. Does anyone want to come in with anything on that comment? Ashwin?
The only time I saw that an exception was made for ACV was for end of life and palliative reason, where they needed to speak to their family. And that was the only time that I saw it being made an exception for that.
Yeah, I mean, this is a whole conversation in itself, isn't it? But my answer would be that yes, it's definitely something we should be using in the right patient with people who know how to do it, rather than just whacking some oxygen flow through a subglottic port. Okay, so Matt, hopefully you're going to answer this question. Humidification in Cpap. So I think we can all pretty much agree that we're not really using non-invasive ventilation as a bridge to extubation or as a treatment modality for this patient group. That's very much kept for hypercapnic respiratory failure. So if we stick with CPAP, is it something that we should be using with CPAP, Matt?
Oh, it's difficult because you've got, well, you try normally putting a filter into the system to reduce the aerosolization of any virus particles. So to achieve anything akin to adequate humidification, you then take out the HME, and therefore you're actually increasing the virus being generated. So have we done it? Yeah, we have on a couple of occasions with a few patients and we've got the opportunity to use a negative pressure room. So that's the only times we've really done it. In other places, it just, because you're taking that filter on the patient side away, we've not been using it. Other options are saline nebs, and if you've got the Aerogen Nevo on your mask and you're in a position to be able to deliver that, that's an effective way of adding some humidity into the airways, or using a jet neb. But it's not something which I think, in terms of, if we're looking about, having said that nasal high flow is not a huge issue, well, we've got evidence to say that you do get aerosolization with NIV. So I think it's something which we ought to be moving away from, or doing in only some very, very controlled environments.
I think it's hard to answer that question in a bit of context as well, because there's several different ways you can deliver CPAP in different machines. So just typical oxygen drivers, so high flow devices, you know, air turbine generators. We have the Venturi type systems. We'll have non-invasive ventilators being used for CPAP, so the NIPI machines, etc. And of course conventional invasive ventilators that have a non-invasive CPAP mode as well, so that might have integrated humidification systems. I think the bottom line is, do you need it? No, because you're not bypassing the patient's airway. But can it be effective in certain patients? Yes, it can. Pearlene, I don't know if you want to come in at that point for any of your experience, and maybe Rebecca as well, please.
I agree with Matthew. To be honest, we've not used humidification with CPAP or NIV at all for the duration of COVID. More to mitigate the risk of infection, as with anything else. So yeah, I agree with Matthew there.
Thank you, Rebecca.
So in the first wave, we didn't use humidification. I think we were quite nervous about, sort of spreading the virus. This time around, we've got a new sort of NIV machines. Our patients are thankfully all on one device rather than cobbled together many different ones. And we're actually using humidification routinely. We've got CPAP units where everybody's in level 3 PPE. And that's kind of something that through, guidance and work with our physiologists that we are, doing regularly. So maybe just a different approach.
Thank you. Okay, moving on to rehabilitation. So can I just focus initially on the ward, so the patient on, let's stick to CPAP high flow. Now, one of the questions that came through was around patients who have been on high oxygen requirements, on high flow requirements, starting rehabilitation, clearly fatigued, breathless, high respiratory rate. What are people's thoughts on starting rehabilitation? Now, Nikki, I know you came in initially with a comment about let's define rehab. So do you want to kick off by just repeating that, and then I can move on to other people's thoughts?
Yeah, I think often, certainly other members of our NDT often see a patient sitting out of bed and say, brilliant, they're rehabbing. And I think it's just important for us to differentiate whether we're getting a patient out of bed and mobilizing them into an upright seated position for a respiratory benefit and to offload work of breathing and to optimize VQ, or are we actually undertaking rehab in order to physiologically strengthen that patient, improve their endurance, etc. And I would say very much, certainly from my experience in critical care, very few of our patients are rehabbing. We've got 4 COVID ITUs. In 3 of them, there's pretty much no rehab happening at all. In the 3rd, which is more of a sort of a weaning ITU, there is rehab happening at the very early stages of that. and mainly it's getting patients out of bed to assist with ventilation, with gas exchange. It's not rehab per se. So I think it's just important to think about that when we're thinking about rehab in this patient population.
Love it. Yes, completely agree with that. Rebecca, can I come into you, please?
Yeah, so I think this is a real balance, isn't it? So we have said with our CPAP patients that within the sort of first 24 to 48 hours of establishing somebody on CPAP or on nasal high flow, that we aren't doing any sort of exercise with them, and then sort of once that's established and they're moving in the right direction, we've kind of set out a bit of a traffic light system with to support our nursing staff to kind of prevent that getting patients out of bed on 80% oxygen and people of 12 or something. We've said that if they are on more than 80%, then they shouldn't be exercising or rehabbing. If they are on a PEEP of 10 or less, and then the next option is looking at bed exercises, then sitting out of bed, and then once they're kind of on a PEEP of 8 or less, and sort of 35% less, 35% oxygen or less, then we can be getting them sort of doing standing exercises, some kind of sort of rehab for their lungs and their muscles. I think in the first wave we saw patients who got a bit stuck on their CPAP, and I think in those cases only really managed to get off their CPAP because of the exercise and the rehab that they were doing. But we are seeing that less this time, and I think since dexamethasone is being used more and kind of the interstitium is maybe proving to be less problematic as time goes on, we are seeing patients who are needing that less, but we are that guideline is kind of there to try and keep the patient safe when we've got lots of redeployed staff supporting them.
Yeah, I think just my basic level or my basic thought around this is when you have someone who's on high oxygen requirements, high PEEP requirements, high flow requirements, physiologically that tells you the severity of their acute lung injury still. And then yes, you don't want people to decondition, but you think about the extra load you place and then what is your rescue strategy? So you've always got to have something you give them that's a bit more, like Matt says, to increase their flow, increase their oxygen requirements, increase their PEEP. We know that with high flow oxygen devices, we are conscious about oxygen consumption in hospitals, and I know that's been a couple of things on the chat. So your default, you never really want to be just whacking the oxygen up or whacking the flow. But most importantly, I think with such a high level of fatigue and anxiety that comes with these patients, isn't it? It's about really not wanting to place that extra load on them and that extra fatigue, because you can very quickly tip some of these patients over the edge. And like going back to what Nikki's point is, sometimes actually the functional exercises are just all they can tolerate. So actually encouraging the nursing staff, like you say, to get people out of bed, to do functional activities, wash and dress, and trying to humanize the ICU. This is where our OTs are amazing, isn't it? And really just concentrating on that rather than being maybe fixated on the rehab element of it, either on the ward or in the intensive care unit. I mean, does anyone else have any comments on that in terms of our critical care teams? Yep, Abby?
Can I just also add to say as well? I've just lost that.
No, go for it.
Sorry, I lost Sam. I was just also going to say to make sure that for these patients that you're not exercising them, on CPAP breaks, and that you're increasing their FiO2 or, their PEEP, kind of keeping an eye on any wean that you're doing at the same time and making sure they're getting adequate ventilatory support whenever we're doing that.
Good point, thank you. Abby, coming into you.
I was probably just going to say, from our point of view, I'm far less organised than Rebecca, saying that they kind of have it all set out with strategies, probably just more so that we're kind of a lot smaller and easier to control. We have sat patients out on 100% oxygen with higher PEEPs, but it's very much from an end of the bedogram of their work of breathing, their comfort, their anxiety, and sometimes being consumed by an air mattress and being stuck in the same bed, is actually making the patient more anxious. Definitely take into account what Rebecca said, that we wouldn't be saying, well, here, have a trial off CPAP and get out of bed at the same time, but it might be get out of bed on your CPAP. How are you? How quickly do they recover? Are they tolerating that? often just that position change is actually reducing the work of breathing and getting them in a far better position. Then we might look at, you know, a trial off maybe on some high flow for some breakfast, but it is, you know, as Rebecca said, it's staging that. And what we would call rehab probably in this instance isn't rehab, it's functional getting out of bed. And we are doing rehab with our trachea patients once we're in that phase, but that over that really acute oxygen hungry kind of phase of their COVID, so you feel a lot more comfortable with doing it.
Thank you, Abby. Nat, what about the happy hypoxemics that need rehab?
Yeah, so I think we might be a victim of our own success with early rehab. And I think some of what we're having to do is reverse education with our critical care staff. So, you know, you might have someone who's sitting there on 100%, you know, they've been there for 3 days, they're relatively mobile in the bed space. And then you've got your critical care colleagues saying, oh, you know, can you get them out of the bed and things like that. And so we're actually having to do a lot of education just to, you know, suggest that actually that may not be the best thing for that patient right now. So we're really looking for a trajectory of kind of improving oxygenation, you know, downward trend in terms of their oxygen requirements. That's not to say that, like, you know, we might have some that have been sitting on 80%, 100% for a week and we kind of just leave them languishing. We really have to kind of judge that as we come. But yeah, we have to be a little bit careful about how quickly we're doing these things.
Thank you. Nikki, then coming to you, Dips.
Yeah, I think certainly in the really early stages as well, we've got to be cautious about actually making the inflammatory process even worse. If we're thinking about the really high work of breathing that these patients have, it generates really huge swings in their intrapleural pressures, and it may actually result in the patients creating a self-inflicted lung injury, which will then worsen the disease process. And I think it's really important that we try to manage that high work of breathing as best we can with high flow rates, with the high flow nasal oxygen, etc. But just being cautious that any rehab per se is likely to increase this work of breathing, and we really don't want to cause any additional lung injury to the patient.
I think that's a really worthwhile point in terms of self-induced lung injury. And certainly in wave one, we saw a number of patients who we felt that with the retrospectoscope, we actually did no favors for whatsoever in terms of the huge pressure swings and yeah, the large tidal volumes which they ended up. And I think that was led to their demise to a degree.
And I think in terms of radiologically what we've seen, another interesting fact is this takes a long time to recover, doesn't it? So your 4-week chest x-rays and your 4-week up to 12-week, and just looking for, you know, it does take that long for the lungs to resolve. This lung injury is severe to the point where you need neither oxygen, high flow oxygen support, or invasive mechanical ventilation. So I think that's a really good point. And do you know, sometimes I think at in the first wave, we realised very quickly that part of the physiotherapeutic assessment is knowing when to do nothing and when it's okay to do nothing, and that was so alien to us, isn't it? And I think this is one of the things for tonight, just thinking about wrapping up, it's been so important because it's known where our added value is, either with its airway clearance, positioning, advice, rehabilitation, when not to, when to, and then the advice to patients as well. Knowing when to bring in other specialist colleagues like our speech and language therapists, for OTs, for psychologists, and actually, like Nat and everyone said, actually saying we're intensivists, really appreciate you think this patient's ready, but actually we don't think they are quite yet. And like you said, Abby, in that same patient, actually when they are on a lot of ventilatory support and non-invasive support, actually saying, okay, this is what we're going to do. It's going to be a targeted rehabilitation. It's going to be about a functional task. We're going to help support you. We're going to explain. We've got a rescue strategy. This is how we're going to do it. So I'm going to give everyone the opportunity to say something. We're bang on 9 o'clock to finish off. Rebecca, is the guidance you talked about available to share for people?
Yes, very happy to share it. Just let me know where the best place to put it is.
Maybe I'll send it just round to all Eventbrite people, because then otherwise you'll be inundated with requests. Has anyone got any pearls of wisdom they would like to share, or any final comments before we close? I'm looking around at everyone. Amy, go for it.
I mean, it's not really a pearl of wisdom, but obviously everything we've discussed, I think to sum it up, it isn't one size fits all, is it? You know, you might have one patient that's on 70% oxygen on CPAP and actually looks grand. And you think, actually, yeah, I think if I put you up to 100%, sit you out, I think that's going to be a good call. And sometimes it is a good call and sometimes it's terrible. And actually that's okay to say sometimes, yeah, I've sat a patient out and then I've come in the next day to find them tubed and proned. And I couldn't have called that. I didn't know that was going to happen. And I think, you know, my advice to everyone listening really is just, you know, use the best clinical reasoning skills that you've got in that moment and assess that patient specifically, and do the best that you can. And if you're ever not sure, just speak to your colleagues. And also, sorry, it was like Natalie said as well, I've never, ever before found myself in the position where I've had to talk a consultant out of me trying to rehab a patient, and it feels so alien. And absolutely, sometimes the hardest thing to do is to do nothing, but actually you haven't done nothing. You've reasoned that scenario and come to that safe decision, but it is hard and it feels alien. But that's it, that's all I want to say.
Thank you. Anyone else for any final comments?
I think that's just it, Rachel. We are all working together in a team. We work in teams for reasons, because we're all there to support each other, and there's a lot of people trying a lot of things with a very unusual patient population. We won't always get it right, and it's just be nice to yourself.
Mm-hmm. Absolutely. And I don't think I mentioned dietitians in this whole podcast, which I'm obsessed with. So I think the one thing I massively underestimated was the nutritional impact of these patients. And I know I've said this on other podcasts, but when we're talking about rehabilitation, it's really important to speak to our dietitians to look at the metabolic demand of that individual patient and also their, you know, nutritional status. So don't forget them. I think I've mentioned every other profession. So on that note, I just want to remind everyone that all of these guys are on social media. So our Twitter handles will be on the YouTube channel page underneath this particular podcast. They are on the tweet as well if you followed this on Twitter, and I'm sure we'll be on the Instagram post. That's not by me, it's by the students. But yeah, so please reach out to anyone on the panel. They're more than happy to answer any of your questions that you might have. And on that note, thank you everyone. Really appreciate you joining me. Thank you so much and take care.